Hello and welcome everyone. So this is a small talk in which I will compare IgA nephropathy from post-streptococcal glomerulonephritis. We know that IgA nephropathy can present as nephritic syndrome, and PSGN is a very important cause of nephritic syndrome. And many times problem-based questions they come, and we have to differentiate between these two conditions. You know that IgA nephropathy, it is due to various hereditary and acquired defects in which there is defective galactosylation of IgA, and these defective IgA they get deposited in the mesangium of the kidney, while post-streptococcal glomerulonephritis, it is caused by the nephrogenic strains of beta hemolytic streptococcus, and which cause the immune reaction. There is immune complex formation. In these immune complexes, they get deposited in the glomeruli and cause the glomerulonephritis. So let's see the comparison between these two. IgA nephropathy can be seen in both children and as well as young adults, while PSGN is more commonly seen in children as compared to the adults. So history will commonly be given in the children in PSGN, while in IgA nephropathy the history in the question can be seen in the children as well as young adults. Then second is there is a past history of infection in both these conditions. That is why it is important to differentiate between these two. So there is past history of infection. In IgA nephropathy, commonly the respiratory tract infection will commonly be given in the question. So, but the important point is that the latent period is very less in case of IgA nephropathy. So it is just there is a history of infection which is just 1 to 4 days back. Besides the respiratory infection, they can also be in history of any GI infection or even urinary infection in case of IgA nephropathy. In PSGN, there is again history of infection, but the infection is recovered well 2 weeks back. So the history of infection is about 1 to 2 weeks back, and it has the patient has recovered from the infection, and after that there is a episode of nephritic syndrome. So this is important that latency is more in case of PSGN. So here it is 1 to 2 weeks, while here it is 1 to 4 days, commonly in less than 72 hours in case of IgA nephropathy. And in PSGN, what type of infection will be seen? One is sore throat, and also skin infections can be seen like impetigo. Next is the hematuria, which will be seen, which can be seen in both these cases. In IgA nephropathy, gross hematuria will be seen, which is recurrent. So this recurrence is an important point to differentiate between the two, and the patient will have episode of hematuria, which will subside, then again recur. So this is a characteristic history of IgA nephropathy. While here you will have a cola colored urine, which signifies hematuria, and recurrence is very rare in case of PSGN. Next difference we can have by the serum levels, complement levels, and complement levels they will be they are normal in case of IgA nephropathy, while because of the excessive complement activation, the complement levels they are markedly decreased in case of PSGN. So this is an important point. Then ASO titers, which signifies infection by beta hemolytic streptococcus, they will be increased in PSGN as it is the cause of this PSGN, while they are not applicable in case of IgA nephropathy. They will not be there. Then next is in immunofluorescence. So in PSGN, there is in the immunofluorescence you will have deposits of C3 and IgG, and these deposits are seen in the subepithelial location, while in case of IgA nephropathy it is written here there is C3 and IgA deposits which will be seen in the mesangium. So this is important for IgA nephropathy. And the last point is there is association of IgA nephropathy with celiac disease, liver disease. So sometimes in the problem-based question, they can give a history of patients suffering from some celiac disease or liver disease, while no such association will be seen in case of PSGN. So these are the important salient uh, differences between PSGN and IgA nephropathy. And let's see some sample questions. So there's this question is 21-year-old woman present because her urine has turned a brown color. It indicates hematuria. Then she states that about 2 months ago, her urine turned brown 2 days after a cold and stayed brown for about 3 days. It means that there is recurrence of hematuria. So there is recurrent hematuria. And this hematuria occurred just 2 days after a cold. So this latent period is very small, that is 2 days after an infection. This happened several times. So she is having recurrent hematuria, and urine analysis reveals the presence of red cells, red cell cast. Then immunofluorescence is showing the presence of irregular deposits of IgA and C3 in the mesangium. So by now you know that this is a case of IgA nephropathy, and linear staining pattern is not formed. Linear staining pattern, it is generally seen in good pasture syndrome, where there is antibody against the glomerular basement membrane. So here they are asking what is the most likely diagnosis. So the points in favor of IgA nephropathy are recurrent hematuria seen in a young adult, and there is the latent period is small, is very short, of 2 days. So there is a past history of infection. And the most diagnostic feature is the presence of IgA and C3 in the mesangium. So here you can make the diagnosis of IgA nephropathy. Another question is 25-year-old man has a 5-year history of celiac sprue. So here they have given a clue. There is celiac sprue. Then 4 days after a mild upper respiratory infection. So latent period is just 4 days. He begins passing the dark red urine, means hematuria. So dark urine persists for the next 3 days, then become clear, only to become red brown again in 1 month. So it is recurrence. Then there is no remarkable finding on the physical examination. In the urine examination, pH 6.5, 3 plus hematuria, and then there is proteinuria presenting as nephritic syndrome. Microscopic examination showing urinary RBCs, no WBC cast, and urine protein level is 200 milligrams. And renal biopsy specimen, what the renal biopsy specimen will show, this is the question. So by these hints, we can make out that this is a diagnosis of IgA nephropathy, because there is recurrent hematuria and there is past history of respiratory infection which has a very short latent period. So now we will see the options. Diffuse cellular proliferation and basement membrane thickening. So this will be seen in membranoproliferative glomerulonephritis. So this is not the answer. The granular staining, it is seen in the post-streptococcal glomerulonephritis. So again, this is not the answer. C, it is right. Mesangial IgA staining by the immunofluorescence. Again, subepithelial deposits, they are seen in PSGN. So not the answer. Then thrombosis within the glomerular capillaries can be seen in hemolytic uremic syndrome. So again, not the answer. So the answer is C. Another question on IgA. 1 week after flu-like illness, a 9-year-old boy has an episode of hematuria that subside, and then 1 month again, urine is red. So there is recurrent hematuria, and there is a latent period of 1 week. And on physical examination, no significant findings are there, and urine analysis is showing proteinuria 1 plus, then hematuria, so presenting as nephritic syndrome. And the urea nitrogen level is 36 mg/%. Creatinine level is bit increased, and electrophoresis shows increased levels of IgA1. So I told you in the lecture of IgA nephropathy that IgA1 is more implicated in case of IgA nephropathy. So again, which of the following glomerular structure is most likely to show the structural alteration? So you know that in IgA nephropathy, the most important structure in which IgA gets deposited is mesangium. So this will be the answer. So, any questions, they are welcome in the comment section. Thank you very much.